It's my pleasure to introduce Dr. Ananth D, who is the ICL opening batsman today. He's a very young, dynamic phacorefractive surgeon from Lotus Eye Hospital and Institute, Coimbatore, and he's also the assistant medical director of this prestigious organization. After completing his residency from Command Hospital, Bangalore, he went ahead doing his phacorefractive training at Lotus Eye Hospital itself under Dr. S.K. Sundarmurthy, who is very renowned and famous in the field of ophthalmology and very illustrious in training a lot of best phacorefractive surgeons in the country. So I would like to highlight that Dr. Anand D has been extremely dynamic, and there is a list of awards that he has won. And one of them is the Young Achiever Award in the I Beach Festival just last year, where Dr. Kudlu had organized. Congratulations. And the cherry on top is the ICL 500 Award at Malmo, Sweden, that Dr. Anandi had been bestowed upon. And as I would take you through, he has done over 25,000 corneal-based refractive procedures. And as far as ICL is concerned, he has done over 1,500 ICL implantations so far. And we couldn't think of anyone better as a speaker taking us through the topic of ICL today. Welcome, Dr. Anandi, and we are looking forward to master strokes from you, sixes and fours in the topic today. Over to you. Good evening, everyone, once again.
Thank you for those words, Dr. Fairuz. Shall I share my screen?
Yes, please.
The screen visible?
Yes, it is visible.
So, Sarvejana Sukhno Bhavantu. Let us all stay safe during Corona time. First of all,
Sometimes the which button, sometimes you can forward it from the mouse pad or.
so first of all, my heartfelt thanks to Partha sir and his team for considering me to deliver this basic talk on Phakic IOL. So, no financial disclosures. I'm just a high volume ICL surgeon, and I love this material, Colamber. I always feel this is the material which has led to the success of this ICL globally. So, success of any refractive procedures, I always think it is dependent upon two factors. How good a doctor is better in counseling or convincing a patient for refractive procedure, and how good he is at managing the complication, if at all, if it happens, even though it's rare in refractive surgery, because all refractive procedures are very simple and easy to master. So over the next 4 or 5 minutes, I'll be discussing in a very simple way how I go about and work up a case of ICL. I always offer ICL to LASIK reject patients, maybe because of inadequate tissue, thin corneas, bigger pupils, a patient who is suffering from moderate to severe dry eye, if there is any family history of keratoconus or ectasia in the family, and for all keratoconus patients who have been stabilized with C3R, 6 months later I advise it, but I will not advise if the keratometric value is more than 58 and if they have decentrated cones. And I also offer, since we are known as a refractive center, majority of the patients do refer ICL patients. And for these subset of patients, I offer it as a primary procedure. There are some patients who ask for a reversible procedure, who are very worried about the complications. I offer it as a primary procedure and to all patients who have got higher degrees of refractive errors. And whenever I'm speaking to them, I always tell them that ICL, avoids all the complications which are associated with corneal-based procedures, such could be flap-related complications, can be regression or ectasia. And I always tell them that ICL never induces dry eye because I'm making incision of just 3 millimeter in a peripheral cornea. And for the patients who demand a good contrast, ICL even today remains the best refractive procedure. I always try to understand my patient by knowing their lifestyle, their realistic expectations from the procedure, their occupational demand, and I also pay attention to some of their decisions. They should not be some sort of patients who are just provoked by the ads which are given by the hospitals. They should have really realistic expectations. And whenever I sit for a counseling, I should make sure it is a family discussion. I make sure who is paying for the procedure and then explain regarding the monetary aspects also. I show them the video. I tell them that this is done a topical anesthesia, completely pain-free. The vision is recovered within 1 or 2 hours, and I just take it than 2 minutes to do the procedure, and it's done on an alternate day. This convinces the patient majority of the times, and I also tell them that if at all, if some complication happens, it is reversible. This convinces them more for the procedure. And as everyone knows, the patient criteria for refractive surgery remains the same. Patient should have completed 18 years, it should have a stable refraction, and the range of correction we can treat until -18, hyperopia until +7, and toric until ±4.5. And we need to pay special attention to past history of steroid response, past history of previous intraocular surgeries, and any evidence of uveitis in the past. Coming on to the examination, the basic examination includes uncorrected visual acuity, discorrected visual acuity. If any accommodating issues are suspected, cyclorefraction is mandatory. And on slit lamp examination, make sure that you rule out all the opacities or scar which is present in the cornea. Clear cornea is a must for ICL procedure because I don't want any qualitative disturbance post ICL surgery because of this scars. I always make sure each and every patient who is getting worked up for ICL will be seen by my glaucoma consultant to get the gonioscopy done and make sure that the angles are open by grade 3 or grade 4 in all the patients. Otherwise, sometimes we assess using our new innovation technique also. To assess the anterior chamber depth, I still rely upon my op scan. FDA tells that the minimum criteria for ICL is 3, but majority of the clinicians we take the bottom line as 2.8. And we should make a note about the pupil also. Any pupil size 5.5, I prefer or defer to do ICL in those subset of patients. Once the patient gets dilated, we need to looking for the lens clarity. Any evidence of early development of cataract becomes an absolute contraindication for ICL implantation. This has to be thoroughly evaluated for the CD ratio, notching any evidence of glaucoma signs. Do not miss out ocular hypertension, other glaucomas. And peripheral examination is very, very important because it's an intraocular procedure. RD later can be blamed for the ICL procedure, so retinal surgeon should thoroughly looking for the periphery. If at all, if he finds out any retinal degeneration, it has to be barrage at least 10 days prior to procedure. Intraocular pressure has to be documented. Tear film assessment is always important. Post-surgery, quantitative disturbance in the vision should not be blamed upon the ICL procedure. And for catometry, I believe upon the topography that is ideal, and any postural curvature changes which are evident on the op scan not to be really given importance because the impact of that is very minimal on the ICL procedure. The most important and the deciding factor is white to white. This is very, very important. To measure the white to white, we have so many parameters: digital calipers, manual calipers, and op scan. Anti-segment OCT cannot measure the sulcus to sulcus. UBM with 35 megahertz can measure sulcus to sulcus in a single picture it gives us. And IOL master overestimates this thing. We should always remember that relative to limbus, sulcus to sulcus distance on an average is around 0.42 millimeter bigger than white to white. And in reality, always sulcus to sulcus diameter varies and undulates in its anatomy. And whenever I'm taking a measurement with an caliper, I make sure that the patient is in a lying down position, especially on my examiner microscope. I get a good magnification, and I take the measurement from clear cornea to clear cornea. Once the AC depth white to white is available, the refractive details are passed on to the star surgicals. They have their own manufacturer's instruction, and based upon their vortex formula, they do provide ICLs. These myopic ICLs are available in four measurements: 11.6, 12.1, 12.6, and 13.2. And these days, EVO lenses have increased their optical diameter by 0.3 to 0.5 mm. For bigger pupils, also we can use these sort of lenses. And we should be always careful whenever the white to white comes between 11.6 to 11 and 12.3 to 12.4. We should be carefully measuring the white to white, because this decides the IOL size. Over sizing may bring about a shallow AC, and under sizing may bring about a cataract in this set of patients. So this is just regarding the details. I think the rest of the speakers will be speaking regarding the technique and the other complications associated with ICL. Thank you.
Dr. Somshila?
Yeah, thank you very much, Dr. Ananth. I think that was an excellent overview. What we'll do is that we'll take a couple of comments each from our panelists. So the panelists to discuss your talk, Ananth, will be Dr. Suhas Adipurkar and Dr. Parimal Desai. And we'll just quickly bring them in. And the plan is to finish up with the first three presentations. And then we're to come back for a more detailed discussion for the first and second talk. So Dr. Hadipurkar, I see you're ready. So if you can just give a quick comment regarding the first presentation.
Well, yeah, thank you, Somshila. Well, it's a nicely made out presentation. Some of the points he brought out are really important. But what I wish to just add is that it is not so important that you have to have a crystal clear cornea for an ICL. In fact, most of the cases where LASIK cannot be done, where there are few foreign body opacities, some even peripheral corneal scars, or post pterygium, all these patients are good enough for ICL, because what matters is the axial and periaxial cornea that's clear, and as long as everything else is good enough. With regards to indications, in fact, post cataract refractive surgery surprises. In fact, it's a great boon if you want to do a piggyback. If the patient has missed out on his multifocal vision, you always have these EDOF ICL that have come, which can be used as piggyback lenses. When it comes to detailed counseling, I am of the opinion that very often when we do a detailed examination, we see some corneal non-progressive lens opacities. It's not necessary to be worried about, because if the patient knows that he's going to get another 15 to 20 years of clear, good vision before the time comes for us to take out the lens, especially in elderly population, this ICL seems to really work well. When it comes to ocular detailed history, what I insist is that in a fully dilated pupil, the lens needs to be checked for its status, the zonulars, especially these are high myopic patients, their zonular status, and of course the peripheral retina will definitely have a look. Another last point that I wish to really bring in is with regards to the lens vaulting, the achieved vault. We do these white to white measurement, but various different techniques. But what I feel is, if you are consistent with one technique and just do it with single hand with a proper protocol, that is enough, because all the research has come out to tell us that the achieved vault will depend up to 40% of the times, on only 40%, to the extent of 40%, on all the biometric measurement that we do. And there are some unmeasurable points that are responsible, like compression from the iris and dampening effect of the ciliary sulcus, are also responsible for giving you the achieved vault. But the good part is there's a wide variation from almost 90 to 1000 micron of post-op vault with which a patient can comfortably stay, because we very often see in a low myo, patients do have shallow kind of the vault is very low, and but it doesn't really matter because you can regularly every year check the patient and things really can work better. So I think because we shouldn't be so much worried about the post-op vault, especially with the newer lenses with the center port, that issue is of a less importance than in the earlier days.
Thank you very much. Dr. Desai, your comments to this? Please unmute your mic for us.
Parimal sir, you can unmute the mic, sir.
Hello. Am I audible?
Yes, carry on. Sir. Just a brief comment, sir, because actually Dr. Gaurav Luthra will have to leave. So we just will take just brief comments.
Okay, I'll just finish it.
We will go on to the detailed discussion again.
Fine. The age group, which should be, it should not be, means at our place, it is more than 20 plus. 18 is a progressive myopia thing. So we select the age group about more than 20. The other thing is we had a bad experience once when we did not measure the pupil diameter. So when we did not measure the pupil diameter, we had a patient complaining of severe glare because his pupil was very big, and we had to explant that thing there. The patient was the son of police officer. So one thing is there. The third thing is Suhas and Ananth, both of them, they told that white to white measurement is very important, because that the whole outcome depends upon that thing. Otherwise, he has covered everything very well. Thank you.
Somshila, can I make one comment only?
Yes, sure, sir.
I think Ananth has done a very good job in a pre-op assessment of these patients. If you have access to a newer generation OCT like KCR2, which will give you a very good measurements, apart from the good AC depth, it gives an angle-to-angle analysis and gives you actual angle measurements like a trabecular iris angle and the actual angle opening distance. They are two important parameters nowadays people take for deciding if patient is suitable or unsuitable. So I think good new generation OCT is part of assessment of ICL nowadays, or of Phakic IOLs.
I have to do more later.
So, Somshila, I think from the first talk, we should have a good take-home message that sizing is very, very important for the right wall to come up. And sir, I would just chip in to put in a question, just quick question about the lens rise. There is a lot of concept about the lens rise. I think 37% of cases still we have surprises in the wall. Tatyal sir, if you could, just quickly brief up.
Sir, we will take this discussion. This is a very important point that Sonu has brought up. But actually, let us take Dr. Gaurav Luthra, and then we'll come back to this very important discussion about the lens rise.